Hello guys, continuing with the series of lesions of the right side of the heart, I'm going to next discuss regarding tricuspid regurgitation. And there are two very characteristic features that are always written in MCQs of TR. One is going to be presence of a JVP finding, that is CV wave. Though I have drawn a line diagram of the same in JVP findings as well, but I'll draw this here as well so that this could become permanent visual memory for you. The second feature would be a pulsatile liver, and this is going to be systolic pulsations of the liver. So let's dive into the topic and get the basics right. Initially in the question, he might have at least one option that could be talking about causes. Now, when I talk about the causes part, most of the cases of tricuspid regurgitation would be of the functional variety. And what I mean by the functional is that there is no problem with the valve leaflets. There is no problem with chordate tendinae or papillary muscles. So what's really going on? If the valve leaflets are fine, if the chordate tendinae are fine, if the papillary muscles are fine, why are we having an insufficiency? The reason behind development of this would be annulus dilatation. You see, tricuspid valve annulus per se, once it dilates, even if the valve leaflets are fine, they will not be able to approximate or close tightly, as the result of which the blood can leak due to pressure difference between the RB and LA during the phase of systole. Now, how is that going to happen? One of the reasons for this could be problems with pressure. Second problem could be with volume overload. And I'll just enumerate a couple of aspects before you. First, with respect to the pressure, and then subsequently for volume overload. So let us assume that a patient is having severe variety of pulmonary artery hypertension. I'll give you the definition of severe pulmonary artery hypertension as well. But at the moment, I just want to say that if the pressure in the pulmonary artery begins to rise, this is definitely going to cause the right ventricle to get gradually dilated because it has to work against a resistance. Right ventricle is anyway a weaker part of the heart as compared to the left ventricle since it has less muscle. So the right ventricle will keep on getting dilated, as a result of which the tricuspid annulus will also get dilated. So in patients who are having pulmonary artery hypertension which is not identified, you see, you very well know that the mean pressure in the pulmonary artery is in the range of about 15 millimeters of mercury. You very well know the formula for that also, systolic plus 2 times diastolic blood pressure, whole thing divided by 3. What I am saying is, if the pressure of the pulmonary artery jumps up to as high as, very huge value as compared to what is normal, more than 3x times, 55 millimeters of mercury or even higher, then the right ventricle will dilate, and the dilatation of the tricuspid valve annulus will contribute to tricuspid regurgitation. Let's look at another situation. This particular patient has had a pacemaker deployed. Now, there's a separate video on pacemaker not present in these series of videos, but in the clinical essentials part. So you can listen to that because you see normally pacemaker per se is not asked in detail. I would say when it comes to a PG entrance exam, they can give you an image related to pacemaker, that is fine. But the modes of the pacemaker is what I've discussed separately. So if you're interested in pacemaker topic, very interesting, believe me, you definitely can switch subsequently after listening to this video to the clinical essentials part, and you would find a pacemaker video there where I've described the various modes as well. But at the moment, all I'm saying is that the wires of the pacemaker ultimately have to go into the heart. So if we are doing a right ventricular pacing in a patient, the wire might be causing damage to the mitral valve, or let me say tricuspid valve annulus, primarily because you see pacemakers could be having multiple wires going and controlling the various chambers of the heart. Like if we are using a standard pacemaker where there are multiple leads present, there could be damage to not only the tricuspid valve but mitral valve as well. But here at the moment, I'm focusing on one of a traditional single lead pacemaker where the wire goes and touches the right ventricular endocardium, as a result of which there's a possibility that it has to be threaded through the tricuspid valve and substantial damage can occur. Then is rheumatic heart disease. You very well know rheumatic, it's mitral valve and aortic valve which are predominantly involved, and when it comes to right side, then tricuspid. Pulmonic may or may not be involved, but yeah, tricuspid can be involved with rheumatic etiology. Next is what they love to ask always in the exam. One is carcinoid tumor, second is syndrome. You very well know the difference. Tumor may not always cause a syndrome, because lots of time the products of the tumor may be metabolized by the liver, as a result of which the syndrome manifestations will not occur. But if those 5-HT derivatives are entering into the right side of the heart, they will cause damage to right ventricular inflow. I repeat my statement. This is important from the exam perspective. In carcinoid syndrome, 5-HT derivatives which are overproduced are entering into the right ventricular inflow, and therefore by entering into the right ventricular inflow, he means tricuspid valve and pulmonic valve, because right side of the heart is the tricuspid and the pulmonic valve would be affected, and the lesions that would be developing here can be remembered by a mnemonic TIPS. Though this is discussed separately also in carcinoid, I just want to repeat this fact before you, that there are two important valvular lesions that you will be encountering with carcinoid syndrome per se. One is going to be pulmonic stenosis, second is tricuspid insufficiency. Both are present. If they ask you to select one, then first select tricuspid insufficiency, and that's the topic that we are studying. The next disease is called as endomyocardial fibroelastosis. Now, when you read the name fibroelastosis, it just tells you that there's going to be fibrosis present everywhere. In fact, this disease is notorious to contribute to heart blocks because it can cause fibrosis of even the conduction system of the heart. So you can very well understand, if a disease can be so deep-seated that it can damage the conduction system of the heart, no big deal, it can cause damage to the tricuspid valve annulus, and as a result of it, tricuspid regurgitation could be occurring. My next patient has received radiation to the chest. He could be a case of Hodgkin's lymphoma with massive hilar lymphadenopathy, and radiation was given to relieve the superior vena cava syndrome of the patient. But then the bad news is it will contribute to damage to the heart as well. Infective endocarditis, the vegetations can be damaging the annulus per se, or we can have a pediatric terminology coming up here. Epstein anomaly is associated with tricuspid regurgitation. They are malformed tricuspid valves. In fact, the first statement that you read for Epstein is inferior displacement of the tricuspid valve, and TR and TS both can be present, but initially malformed valve leaflets, they will not be able to close properly. So we are going to have a development of a tricuspid regurgitation in the patient. For Epstein anomaly, two important aspects to be remembered would be: one, this will develop in a baby who's born to a mother who was on lithium, like she is a case of maniac depressive psychosis, and she had an accidental pregnancy. She continued taking lithium in the first trimester, so teratogenicity has occurred. And second, Epstein anomaly can be associated with Wolff-Parkinson-White syndrome, and you know, one of the very characteristic ECG findings of Wolff-Parkinson-White syndrome would be presence of a delta wave. So you need to get the causes right. I would especially like you to remember carcinoid syndrome and Epstein anomaly, the allied aspects that I've highlighted in color green. Though obviously you are expected to remember entire or the overall this entire information, but I want to highlight that tricuspid regurgitation in majority of cases is going to be functional. Primarily the leaflets are not affected, the chordate tendina are not affected, but still you're having a disease manifestation. Now let us look at how the disease will evolve in a patient, what will be the clinical features, and then I'll also talk about a very characteristic JVP finding. Because there's going to be problems with the right side of the heart, it will not be able to send blood effectively to the left side. See, what's happening here is right ventricle blood, I can just highlight this in this diagram itself. Right ventricle blood is leaking into the right atria, so all the blood of the right ventricle that should go in the pulmonary artery is going waste back into the right atria. After all, the function of the right ventricle is to pump blood into the pulmonary artery. If the blood is going to go waste by going like in this direction, then the input to the lungs is lesser, less will come to the left side of the heart. So these patients would be having low cardiac output. I've tried to explain why is it written effort intolerance in these patients, because the moment we read this line, our first thought process is, okay, disease is in the left side of the heart. That's okay. I mean, effort intolerance will always occur with problems of the left, but ultimately right and left are coupled together. If the right is not going to be able to send blood effectively to the left side, there would be effort intolerance in the patient. The next finding that will develop in this patient will be a CV wave, which will be written as visible neck pulsations. In fact, the patient himself will point out, you know, he might just move his shirt collar and say, doctor, have a just look at these peculiar pulsations which are present in my neck. Then because right side of the heart is getting involved, and there could be hepatomegaly in these patients, pulsatile liver as well. So the person is complaining of abdominal fullness and discomfort in the right upper quadrant. And because of this tummy discomfort, he also says that my appetite has decreased and I'm losing weight. So I decided to have a good look at this patient. I did a general physical examination and then subsequently a cardiovascular examination. So let us look at what did I find. One of the highlights of this particular disease would be understood like this. You can take this to be representation of the jugular vein. After all, the jugular venous system, internal and external jugular vein. You can check the JVP in internal jugular vein. That's the primary source. If internal jugular vein somehow is you're not able to pick up, you can check it out in external jugular vein also. But in the exam, if they ask you to select one, first answer is obviously internal jugular vein. So what I'm showing here is in a downward direction, I'm showing a X descent because X is a negative wave and it occurs during the phase of ventricular systole. Now what's happening is ventricles are contracting, both right and the left. The left will obviously be able to eject blood into the aorta, no problems. But in this particular chap, what is happening is, and let me just modify the diagram a bit. You are very well aware that the valve leaflets always tend to bulge upwards whenever there is a systole. But in this particular chap, there is a defective coaptation of the valve leaflets, due to which some blood is able to leak up from RV to LA. Now I have shown two vectors. One is in color blue, the other one is in green, and both are going in opposite direction. If they are in equal strength, they will cancel each other. And if they cancel each other, the examination finding that I'm going to get in my patient would be an absent X descent. In fact, you can appreciate this better if I just draw the routine tracing. You have a AC V wave and then a X and a Y descent. So I've just drawn normal JVP waves before you. And what I'm saying for my particular case is that if I increase the severity of the green vector, you see, as compared to earlier, what I have now done is that I have increased the severity of tricuspid regurgitation. So the vector that is coming up from bottom upwards from RV to RA, I mean, obviously RV and RA are not aligned bottom upwards, but from this line diagram, what you can see for vectorial perspective or vectorial analysis, that the green vector is stronger. So this might actually even push up the X. Well, this is what I'm saying. The A wave of the patient is going to be fine, C is going to be fine, but there's going to be no X because you can see the vector is pushing everything upward. So the JVP might take off like this. And the finding that you will encounter in this patient will be slightly different from the way you see in a normal person. I have drawn in green a tracing for a person of severe tricuspid regurgitation, and this that I marked with the star mark here is what is called as a CV wave. This is what I was talking about right in the beginning of the discussion, that CV wave is one of the very good tick-up points for these patients. Why CV wave? Because after C there should be X. There is no X present. So anything that goes up after the C wave would be a positive wave, that is, would be called as a CV wave. And where I have put a tick mark, I want to say that I can describe this like a roller coaster ride. I mean, if you go up steep, then you fall down steeper also. So where I put the tick mark is what is called as steep Y descent. This description is one of the characteristic words that would help you pick up a question of I would say tricuspid regurgitation. And for the CV wave that I have highlighted, and I'm writing it once again, is because they might use a classical sign that is called as, or name also, because they love to talk about classical signs, and I've talked about a lot of classical signs in aortic regurgitation. So one that I taught you at the moment is called as Lancisi sign. As I proceeded with my further examination, I found that this chap was having a hepatomegaly. And I also noticed some pulsations with respect to the liver, and this condition will be having systolic pulsations of the liver. I've already explained to you, I'm highlighting this again. If he says the word pre-systolic pulsations, it's going to be tricuspid stenosis. Now we will focus on the murmur of this case. So this would be a pan-systolic murmur. You see, during the phase of systole, there is leakage of blood, so it will produce turbulence. This turbulence will contribute to development of a murmur. So I have shown a murmur which is different from the crescendo, decrescendo murmur that you're going to be reading for aortic stenosis or for pulmonic stenosis. Here, the intensity of the murmur will remain constant all through. So either he will use the word holosystolic murmur. I mean, the classical description in a medicine book for tricuspid regurgitation would be blowing holosystolic murmur present all through the duration of systole, or an alternative term that is used in most multiple choice questions, because somehow I think holosystolic word makes it relatively easier for you to pick up. So I have seen lots of questions saying the word pan-systolic murmur. And what I will also do is I will try to see that, because pan-systolic murmur is found in mitral regurgitation also. So I want to be sure that am I dealing with MR or am I dealing with the TR. So what I did was I asked my patient to take a deep breath. On inspiration, all right-sided murmurs tend to become louder, and that is what happened here. that in this particular chap, when I asked him to take a deep breath, because of more blood supply, more turbulence, the murmur became relatively louder. And this maneuver that I performed before you at the moment helped me differentiate this condition from that of, or this murmur from that of mitral regurgitation, is what you read as Caravello's sign. So the statement to be remembered is all right-sided murmurs tend to become louder with inspiration. I have said that in the discussion of murmurs. In fact, once you are done with this, not only listen to the pacemaker aspect, but also listen to the murmurs topic, where I've highlighted all murmurs tend to become more when it comes to squatting or isometric exercise, or I can say vice versa also. All murmurs will become lesser on Valsalva, standing amyl nitrate. Why Valsalva standing amyl nitrate? Because standing and all of these aspects, Valsalva standing amyl nitrate, all of them are going to contribute to decrease of venous return. So all murmurs will decrease in intensity except two: HOCM and mitral valve prolapse. I'm saying it verbally at the moment because this is discussed at appropriate times required wherever in the app. All murmurs tend to become lesser with Valsalva standing amyl nitrate, except HOCM that tends to become louder and mitral valve prolapse that tends to become longer. So dynamic aspects are definitely asked, and what I've done here is another dynamic auscultation aspect that I've highlighted before you. We'll be now focusing on the workup of this patient. So I'll be doing a ECG. And since we are talking about the right side of the heart getting involved, so there would be features of right axis deviation and right ventricular hypertrophy. Though I would say that ECG is not very good to identify hypertrophy. There are various criteria which are present, but none of them are having a substantially high sensitivity specificity. So I have not mentioned any specific criteria for RVH. Unlike in left ventricular hypertrophy, I have discussed criteria in aortic stenosis discussion. For RVH, because none of them are having a high sensitivity specificity, so therefore I have not mentioned them. And at the same time, because I said that there is a possibility that in the pediatric version he would love to ask about Wolff-Parkinson association with especially cases who are having Epstein anomaly, so delta wave could also be picked up in the ECG. If I'm going to run the chest x-ray, because this is going to be problem of the right side of the heart, right ventricular enlargement, right-sided enlargement will definitely be seen. Even right atria would also be enlarged. You very well know that right heart border is not formed by right ventricle, as I've said multiple times. It is the right atria which forms the right heart border along with SVC, IVC. So the prominence of the right atria, prominence of even the SVC, IVC can be seen in this patient. When I'm going to do a echocardiography, that will definitely be the investigation of choice, and it will show defective coaptation of leaflets. It will also show on Doppler leakage of blood from RV to RA in this patient. And in fact, one more finding with respect to Doppler which is worth I would say remembering for this topic is reversed systolic flow. I say a very peculiar statement, reversed systolic flow in the liver. Now why is this happening is because of backflow blood. No, RV blood is going to RV. So you see, when the heart is contracting with force, the backward flow of blood is contributing to reversal of systolic flow in the liver per se, which is very peculiar because obviously the blood has to flow in forward direction during systole, but here due to the back pressure changes, I have highlighted this term reverse systolic flow in the liver. Now we will be focusing on what will be the treatment for this patient. So initially I'll be putting this person on salt restricted diet and diuretics. That will help us in easing off the component of especially the pedal edema and the hepatomegaly and maybe an ascites that could develop in these patients if it goes undetected. I did not describe ascites during this discussion because most of the time the findings in this patient are so prominent. The neck pulsations are so prominent, or I would say the effort intolerance component is so predominant that diagnosis is made before you have a possible ascites developing in this patient. But yeah, I mean, because I want to prevent the problems with right-sided failure, so I have used diuretics in this patient. Now for the treatment of this patient, there will be two terms that will be written, and those short forms that you read in multiple choice questions are to be understood. Either you will read the word TVRP, R capital small p, or you will read the word TVR. R capital here stands for replacement, whereas RP would stand for repair of the valve. And on a comparative basis, I will always be preferring a repair over a replacement, because you can very well understand then once you replace a valve, not only the cost factor comes in, and obviously, I mean, I'm not going to replace a valve just because of the cost fact. If it's going to be severe damage, then yes, I mean, if infective endocarditis has destroyed the valve, let me say if a person is having a TR of the acute variety due to drug abuse like infective endocarditis, because we always read about, I would say, right-sided endocarditis, tricuspid regurgitation developing in drug abuse per se. So I'll obviously give antibiotics, and the drug is contributed to, I mean, bacteria going in, and the valve is totally destroyed, then definitely a valve replacement. But otherwise, because majority of cases are gonna be of chronic presentation, the functional component coming up, so cause specific treatment, like if it's a pulmonary artery hypertension, then pulmonary artery hypertension definitely has to be managed for these patients. And as I said, I mean, pulmonary artery hypertension always contributes to development of a early diastolic murmur. You see, what happens is, traditionally when you read about PH, it is always mentioned that the higher pressure will contribute to leakage of some bloods across the pulmonic valve. In you and me, pulmonary artery will not have pressure sufficient to cause opening of the pulmonic valve, obviously because valve opens during the phase of systole. But in person who's having pulmonary artery hypertension, during the phase of diastole, the pressure is so high that it is causing the valve leaflets to be forced open, causing a little bit of blood to leak back. So traditionally in pulmonary artery hypertension, we read about a early diastolic murmur. However, what I said was more extreme. I said pulmonary artery hypertension is going to cause a gross dilatation of the right ventricle, and therefore there would be a functional tricuspid regurgitation developing in this chap, which is going to contribute to a pan-systolic murmur. So you can see that pulmonary artery hypertension, if is of the mild variety, the word is mild variety, you have an early diastolic murmur. As the disease becomes more severe, you also have is a pan-systolic murmur. So if he mentions in an MCQ which murmurs can be seen in pulmonary artery hypertension, you very well know pulmonary artery hypertension has a loud P2. Everybody knows that, right, from third year of medical school. He will ask you in the competitive exam what murmurs can be seen. So you have to mark both are correct, especially for any set exam where multiple options can be correct. Early diastolic is standard bread and butter. We all know that, because pulmonary artery hypertension will operate during diastole. Pulmonic valve opens in systole, right? What I am saying is pulmonary artery pressure is high. It is separating the valve leaflets even in the phase of diastole, causing a bit of blood leakage, so early diastolic murmur. But if the severity of pulmonary artery hypertension increases, it would be a pan-systolic murmur. And what I also did was I checked out the intensity of this murmur when the person was asked to breathe in versus breathe out, and I noticed the fact that the intensity of the murmur was increasing with inspiration, and rather I would say the intensity of the murmur will decrease with Valsalva and standing. This aspect I had said verbally, so I am just putting that on record here. Valsalva or standing, they contribute to decrease in venous return. So if less blood will come in the right side of the heart, the turbulence part will definitely reduce. But this component that I've highlighted currently on the slide, important aspect to be remembered over and above the aspect of Lancisi sign and systolic pulsations of the liver. So if you get these facts right, I mean, you are on track, or you are able to continuously solve MCQs on these topics. The next valvular lesion on the right side of the heart that I'm going to teach you is pulmonic stenosis. Mild to moderate usually does not come to clinical attention. It's the severe variety that we will learn about, and the echocardiographic criteria I'll explain to you, just like we have studied the criteria for severe tricuspid stenosis with respect to the size and the transit time, or I have described severe and very severe mitral stenosis in the earlier lectures. Mitral stenosis anyway is covered in the murmurs topic, as you would have noticed. Now when we focus on the causes here, the number one cause would be congenital, and at this juncture I want to be repeating the statement that in tetralogy fillet we do not have a pulmonic stenosis. TOF would be having a subpulmonic stenosis. Here I am talking about isolated pulmonic stenosis. So this is primarily, or in most of the cases, a pediatric presentation. Point number 2 is important from the exam perspective, because they love to ask about syndromes per se. So that's itself a standard question. Which valvular lesion is common in patients of Turner syndrome versus patients of Noonan syndrome? You very well know that Noonan syndrome and Turner syndrome patients might be looking the same. In fact, I would like to here just bring to your notice this very characteristic finding that you would have read about so many times in your books, that is webbing of the neck, which is a very characteristic feature that you encounter in Turner and also noticed in Noonan syndrome as well. As I said, in Turner syndrome, which is going to be 45XO, the commonest valvular lesion that we encounter is bicuspid aortic valve. And after bicuspid aortic valve, we do have even coarctation of aorta present in these patients. But since we are talking about valvular lesions here, so that would be the primary congenital heart disease that could be occurring in these patients and would contribute to aortic stenosis. Noonan would be rather looking the same. The phenotype will be same, but genotype will be different, because in Noonan syndrome, it could either be male or it could be female, but they would be 46XX and 46XY. But when it comes to Turner, it is 45XO. In Noonan syndrome, they also would like to ask you which chromosome is involved. So while I'm writing the problem here, which is that of a dysplastic valve, you can tell me which chromosome is involved and genes, because chromosomes and genes are something which is, you tend to develop knowledge of them over a period of time. When we try to cram chromosomes and genes on a single day, it becomes just too much. So whenever you read a disease and you read about a chromosomal defect or you read about a gene per se, just try to make a note of it and note it down separately so that you have a list ready which can be remembered subsequently. So what I've said is chromosome 12, PTPN1 gene is involved here. And then the third cause is again important from the exam perspective, carcinoid syndrome. I have explained even in the earlier part of this video that in carcinoid syndrome, the 5-ST derivatives will be entering into the right ventricular inflow. So when I say RV inflow, it's the tricuspid valve and the pulmonic valve that will handle the brunt. Maximum impact will be taken by the tricuspid valve because it is present ahead of the pulmonic valve. So I mentioned a mnemonic for the valvular lesion tips: tricuspid insufficiency and pulmonic stenosis, the topic that we're studying at the moment. And I would like to remind you that if they ask you to select single one, valvular lesion in carcinoid syndrome, first answer is tricuspid insufficiency and then is rheumatic. Now for point number 4, I know the fact that when I am writing this, you will say, sir, we have read in pediatrics in OP Ghai that rheumatic does not cause pulmonic valve involvement. So I agree to this difference of opinion between certain books, because OP Ghai categorically mentions pulmonic valve is not, the word is not involved, but then some other books mention pulmonic valve may be involved. So I would like you to take this with the right perspective. I mean, if he's saying a question which is saying not involved in rheumatic, pulmonic valve, otherwise the rarest involved, again the answer is pulmonic valve. So both the statements are correct and they do not contradict each other. It is just that in Indian studies they may not have found that pulmonic valve is involved, and in some cases abroad they might have detected pulmonic valve involvement, might have occurred in few cases. Then as I explained right in the beginning, mild to moderate variety will not contribute to any symptoms, but when it comes to the severe variety of pulmonic stenosis, yes, the symptoms will appear. So he will ask you about a pressure gradient, and what I mean by pressure gradient is that pulmonic stenosis will operate during systole. When the right ventricle is going to be decompressing into the pulmonary artery, there is going to be a resistance present. I'm just going to symbolically represent this. I said when the right ventricle is ejecting into the pulmonary artery, there is a physical narrowing which is present, and whenever there is a narrowing, there will be a pressure gradient. So the question said, what should be this pressure gradient, or what should be the mathematical value? I want you to remember this number. Severe pulmonic stenosis is when the right ventricle is operating against a pressure gradient of as much as 50 millimeter of mercury, which also explains that these patients will be having a compensatory right ventricular hypertrophy. When you have a hypertrophy, the oxygen demand of the heart will increase, and when oxygen demand increases, there can definitely be mismatch between demand and supply, because demand has increased but the coronary artery supply is still the same. So angina will definitely be a feature present in these patients. So let's enumerate some of the common features that would be seen in these patients. The first feature will be that because the right side of the heart will not be able to effectively send blood to the left side, so therefore effort intolerance will come in. After all, if input is lesser, output will also be lesser. So when you read the question effort intolerance, you obviously start thinking in terms of problem on the left side of the heart, but it is stemming ultimately because left and right are in sync. If the right will be having a problem, the left will also be affected. After effort intolerance and fatigue, that will be the predominant complaints. Because there is a right ventricular hypertrophy, there will be a mismatch between the demand and the supply. So either he is going to write the word subendocardial ischemia, or is going to write the traditional chest pain, though a child may not be able to explain chest pain, and every time it occurs, he might even become unconscious. Now, based on the symptom profile, whether with respect to Noonan syndrome or a Carson syndrome or a congenital presentation, let's have a look at how the murmur will be present. I mean, that would be one of the characteristic features which is present here, and then how the disease severity will affect the duration of the murmur as well. I'll just symbolically here represent that the pulmonic valve orifice is substantially narrowed, contributing to pressure gradient of as high as 50 millimeter of mercury, in contrast to aortic valve orifice, which is just fine. So when the right ventricle will work, this is gonna work perfectly. But on the right side of the heart, there is definitely gonna be turbulence when the blood is ejected into the pulmonary artery of the patient, and that will explain why this is a systolic event. So there will be an ejection systolic murmur. I have represented S1, S2 and S1 before you. Period between S1 and S2 is called as systole. And what we have first is a ejection click. Ejection click basically represents the opening of the aortic and the pulmonic valve. So this pressure gradient will first open the valve, and once the valve is opened, then the blood is ejected, and that is when you get the turbulence. So what's going to happen in these patients would be a development of a crescendo decrescendo murmur. The intensity of the murmur will first rise and then will gradually level off. So this that I've shown before you is called as ejection systolic murmur. However, if I increase the severity of the disease, if I make this orifice even much more smaller, then what's going to happen in these patients is, let me just draw a line diagram here to highlight this fact. I said if this orifice is narrower as compared to, let's compare two patients. One is having, let me say, moderate variety, another one is having severe variety. So the green can represent moderate and the pink one that I've highlighted is representing the severe pulmonic stenosis. So when you compare the two patients, instead of drawing two diagrams, I'm imposing in the same diagram itself. The pink representation shows the fact that there's a severe problem present. So there will definitely be a compensatory right ventricular hypertrophy, which will be much more in amount as compared to the one that is present in moderate. So if the pressure is gonna be higher, I'm just gonna draw an extra plus here to say that in severe variety of pulmonic stenosis, if the pressure here will be higher, this pressure will cause an earlier opening. See, there's a hypertrophy, no? This hypertrophy will generate more force, so it will cause an earlier opening, and because of earlier opening, what is happening is that the ejection click will move closer to S1. I repeat the fact once again. You are comparing two patients, moderate versus the severe variety of pulmonic stenosis. In the severe variety, the RVH will be more, the power generated will be more. So more power means the valve can open relatively earlier. So therefore, I have shifted the position of the ejection click, which means the fact that the murmur will be able to start relatively early. Therefore, the duration of murmur will increase. But what I am also trying to explain to you here is that the gap between the S1, which was present between S1 and ejection click initially, that's the green line, and the gap between the S1 and the ejection click when you compare with the severe variety, or let me say even if it's progressive, even then I can say like in carcinoid syndrome, disease can be progressive. So therefore the gap will reduce, and it is no big deal that as the severity increases, let me say in carcinoid syndrome, the 5-HT derivatives are flowing into the right side of the heart, ejection click will keep on coming closer to S1, and the murmur might be starting even from S1. So you will notice the fact that lots of time when I'm showing a ejection systolic murmur, I am beginning it right from S1, because if it's the severe variety, the gap between S1 and ejection click keeps on reducing, that the murmur tends to take off even from S1 as well. So that concept is what is important here. I mean, after all, the lot of queries that I get from students is that, sir, why did you not draw the murmur from S1 like you did in aortic stenosis? Well, in aortic stenosis, I said severe, so that means murmur is starting already from S1. But here I have tried to show the magnitude of severity will decide how early or how late a valve would close. You see, I'm talking about normal opening versus an earlier opening. So once there's an earlier opening, the ejection click will come closer and the gap will become relatively lesser. At this juncture, one more fact which is to be remembered. In fact, I would like you to note this statement with me, and this is important for MCQs, that all right-sided events tend to become louder on inspiration. Remember I said that? So what's the big deal? Listen to the big deal. All right-sided events tend to become louder, increase in intensity with inspiration, and that is what I have been saying all through this video and even through my earlier videos. But now there's a question that said except. So I want you to remember this, that when it comes to pulmonary ejection click, this is the only finding which tends to relatively become lesser in intensity as compared to others which always tend to increase in intensity with respect to inspiration. This is itself a MCQ statement which I would like you to remember. I repeat it again so that this becomes a long-term memory for you. All sounds, or I would say murmurs per se, would be increasing in intensity with inspiration, especially with respect to the right side of the heart, but the only exception is going to be a pulmonary ejection click. Let's have a look at some more auscultatory findings for these patients. When you're gonna hear the S2 of this patient, the A2 intensity will be fine, no problems with aortic valve, but the P2 component might be very, very soft. So you will notice I've written P2 in small alphabet or rather smaller size to say that P2 will usually be soft in these patients. As a result of it, you may either not be able to hear it, and therefore he might use the word single S2, or he might just say the word soft P2, or soft S2 can also be written soft S2 primarily to highlight that P2 component is reduced, so overall intensity of sound can be reduced. Also in these patients, because there is a physical obstruction, so even the right atria will have to work against a resistance. So when the right atria will be having a hypertrophy, the extra force generated by the right atria, the right atrial kick will be generated because it's after all working against a resistance. So therefore you will read about right-sided fourth heart sound developing in these patients. In fact, I've highlighted this couple of times that fourth heart sound can be found in patients whenever there's a atrial hypertrophy. I mean, like in systemic hypertension, we tend to have left-sided S4 because of LVH and LAH. Here in pulmonic stenosis, you would be having is a development of right-sided S4. So I'll just quickly summarize before you the auscultatory findings that I've said for this condition. Before we talk about the workup, it is gonna be a soft S2 written. There's gonna be S4 present. That's gonna be right-sided. It's gonna be an ejection systolic murmur, and the ejection click will keep on coming closer. So there's a possibility that the murmur might be starting even from S1 as well. When I do the workup of this patient, since the problem is on the right side of the heart, when I do a ECG, it will be showing standard findings of right axis deviation. I mean, anytime right side of the heart gets involved, it's right axis deviation and right ventricular hypertrophy. ECG criteria for right ventricular hypertrophy are not very reliable as compared to that of left. So for chamber enlargement, we anyway rely on echocardiography. When I'm going to do a chest x-ray on this particular patient, right ventricle will be predominantly enlarged, and therefore right ventricular enlargement will not affect the right heart border. I have highlighted this multiple times. Right ventricle forms the base, so you will notice that the apex of the heart will be lifted upwards. You are aware from your radiology classes also that when the left side of the heart enlarges, left ventricle enlarges, the apex is inferolaterally I would say positioned or inferolaterally displaced. But whenever right ventricle is enlarged, the apex will be rather superolaterally displaced. I repeat my statement once again. Hypertension, left ventricular hypertrophy, apex is inferolateral. And when right ventricle is enlarged, you would have an apex which is turned upwards. And in tetralogy of Fallot anyway, you read about right ventricular hypertrophy of the concentric variety, which causes a boot-shaped heart as well. Though here I've not used the word boot-shaped, I've just used the term apex is moved superolaterally. To confirm the diagnosis, I'll be doing a transthoracic echocardiography. I can measure the pressure gradients as well, and then it's the time for treatment. If he says what's the best treatment for these patients, your answer would be a percutaneous pulmonic valvotomy. So anyway, nowadays we are not doing a open heart surgery for valvular lesions. There is no need. We can simply go in for a balloon dilatation for this patient. At this juncture, I hope you are realizing the fact that when it comes to calcified aortic stenosis, you never do a balloon dilatation. I have explained this in the topic of aortic stenosis in the earlier part of the valve discussion, valvular lesion discussion, that whenever it's a calcified lesion, in calcified lesion, if you deploy a balloon, the balloon will cause the valve to break into pieces, like a biscuit will break into pieces or like a cookie will crumble, and those fragments will embolize to the brain of the patient. So in calcified aortic stenosis, balloon dilatation is definitely a big no. So I'm going to write it and just put a line over it to highlight we don't do it. But when it comes to a dysplastic valve, like I described that Noonan syndrome could be having a dysplastic valve or a malformed valve, because there is no calcification, so there is no risk of any embolization of any fragments towards the brain, which is the reason why we can go in for a percutaneous pulmonic valvotomy. The subsequent valvular lesion that I'm going to describe to you is pulmonic regurgitation, and one of the important causes for this can be pulmonary artery hypertension. The logic is simple as what I described. Even with respect to tricuspid regurgitation, there could be an annular dilatation of the pulmonic valve. So there could be leakage of blood occurring from the pulmonary artery into the right ventricle of the patient during the phase of diastole, and therefore there could be an early diastolic murmur developing in the patient. Though if pulmonary artery hypertension will become severe, then even the tricuspid annulus will dilate and you will be having a pansystolic murmur or tricuspid regurgitation. I have highlighted this aspect even in the earlier part of the discussion, so that because they usually ask about PAH and the associated murmurs. So pulmonary artery hypertension obviously has a loud P2, but it can be having a diastolic murmur as well as a systolic murmur that I have reiterated right now. We are aware of the fact that in tetralogy of Fallot, there is going to be a subpulmonic stenosis. So when a surgeon is doing a tetralogy of Fallot repair, if there is an overcorrection of the right ventricular outflow tract obstruction, then this overcorrection can contribute to the opposite developing in the patient. He had a subpulmonic stenosis but ended up after surgery with pulmonic regurgitation. The same is the situation after a balloon valvotomy. Just a few minutes ago, I had told you that for any dysplastic pulmonic valve, we can easily go for a balloon valvotomy. But if this procedure is overdone in the patient or overcorrection is done, then the opposite can also develop. And then Marfan syndrome anyway has problems like MVP, aortic dissection, MR and TR, and even a pulmonic regurgitation, which is possible. Let's now have a look at the line diagram, which I'll make before you to represent the murmur. And this would be a early diastolic murmur. Let's see the reasons why it is coming up. This is the aorta of the patient. This is the pulmonary artery, which I have bifurcated into the two. And because of the substantially high pressure, there is a dilatation of the annulus, which is causing some blood to leak into. The amount of blood will be variable depending on the severity, but the point is at least some blood is leaking during the phase of diastole. So when I'm going to auscultate this person, systole is going to be fine. But during diastole, second heart sound is A2 and a P2. I'll just use a different color to highlight this. I said this blood that is leaking back is causing turbulence or a murmur. So the moment the P2 will occur in the patient, there would be leakage of blood, and the duration of the murmur will depend upon how much blood is leaking. Let me say only 5 ml, or let's take substantially a minimal amount of blood is leaking. So the sound will die down very soon. Why? Because there's a limited amount of blood that is coming in. So you will always read the word early diastolic murmur is a feature with pulmonic regurgitation occurring secondary to pulmonary artery hypertension. And this has been discussed even in the murmur section, and I gave a classical name to it, Graham-Steele murmur. I repeat the fact once again, Graham-Steele murmur is seen in pulmonary artery hypertension due to the dilatation of the pulmonic valve annulus, and therefore you get an early diastolic murmur in these patients. The duration will substantially reduce, so sometimes you will read the word only, the word written decrescendo murmur. Why these patients would come to you? The clinical profile of pulmonic regurgitation will be less input to the left hand side, so easy fatigability. Then breathlessness. Why breathlessness? Not because of pulmonary edema. There's no pulmonary edema here. Rather, less blood going to lungs. Blood is going away from the lungs. It should be going into the lungs. It is going back into the heart from the lungs. So less blood supply to lungs would be explaining the pulmonary, I would say, insufficiency from the perspective of breathlessness. It is less pulmonary blood flow contributing to it. Plus, the right side of the heart will be affected. So subsequently, pedal edema can come up. Abdominal fullness can be coming up. And you will be able to pick up the question anyway on the basis of murmur. And that is the reason why I have put the murmurs lecture ahead of all these valvular lesions, or I would suggest you to listen to murmurs after this, is because you will get a holistic view. You see, when you read the topic of murmurs, first thing is it looks overwhelming, but when you read all those diseases together and all the line diagrams that are made, if you can make them with me when I'm making them like the way I did right now, then you would be able to understand the development of evolution of the murmur per se. Now let's have a look at the investigational choice for this condition. I have always said that echocardiography is the best way to identify any valvular lesion. I stand by my statement, but for pulmonic regurgitation, I was telling you aspects like overcorrection done during a tetralogy of Fallot repair, overcorrection done during a balloon valvotomy. So when you are having a malformed valve and that malformed valve have also been surgically operated to the level that it has now resulted in an opposite lesion, I need exact anatomical details. I said the valve was already defective. Somebody operated on it and did mess of the situation by creating a valvular region opposite of what was initially present. So the valve anatomy is grossly distorted from what it is present in a normal person. So because of the gross distortion of the valve anatomy post intervention, I would need an exact anatomical reconstruction of the valve malformation. For that, cardiac MRI will be superior as compared to echo. Echo will definitely tell you there is a pulmonic regurgitation, no issues. But because I want a anatomical reconstruction, because after all, once we know what is the defect, we'll be able to treat it. So anatomical reconstruction of the valve will be better with the cardiac MRI as compared to echo. So echo will anyway pick up the disease. And for treatment of these patients, I will be using diuretics to handle problems that will occur with right-sided decompensation. And the treatment of choice for this condition would be answered as transcatheter pulmonic valve replacement. You can understand that the pulmonic valve has already been made a mess of, because most of the time the case that will be given to you in this particular pulmonic regurgitation MCQ will be that of a patient who's already undergone a surgical correction. If he wants to give you a case of pulmonary artery hypertension, you will anyway be able to answer treatment of pulmonary artery hypertension, right? If you treat PH, the problems will gradually at least mitigate. And as such, for pulmonary artery hypertension, if the valve is defective, the primary treatment is control the root cause, and then the problem of the patient will be attenuated. But here we will have to go for a valve replacement because already the valve has been damaged beyond repair. Based on this input, we will now talk about a summary of findings of the valvular lesions of the right side of the heart, and I would suggest you to draw this with me. The valvular lesions that we have discussed are TS, TR, PS and PR. So you can just make a 4x2 table here. What I'll be jotting down here will be the JVP findings of these patients and then the aspects related to murmurs. So let's just remember these facts here. In tricuspid stenosis, the right atria has to work against a resistance, and because of the physical obstruction, the negative wave, that is Y, will be blunted. But in tricuspid regurgitation, I spoke about Lancisi sign and a CV wave. I also said that this would be like a roller coaster ride. So if it goes up, the fall will also be steeper, so a steep Y descent. Pulmonic stenosis will contribute to large A wave, again because there is a physical obstruction in the right hand side, so RA will have to work harder. Same is the situation with pulmonic regurgitation, I mean stress on the right side of the heart. So JVP findings will definitely give you some kind of an idea with respect to what kind of disease is you talking about. Let's talk about the murmur here. In tricuspid stenosis, the murmur that you encounter will be a mid-diastolic murmur becoming louder on inspiration. In TR, he will be talking about a pansystolic murmur. In pulmonic stenosis, it will be a crescendo decrescendo. It will be starting from ejection click, but as the ejection click will come closer, it will start from S1 also. And then when it comes to pulmonic regurgitation, remember Graham-Steele murmur with PH, it would be early diastolic murmur. Let's also sketch them down. It will take some time, few extra, I would say, seconds, but then I think this would be worth the effort. You would be having a murmur in middle of the diastole. In pansystolic murmur, we also call it a blowing holosystolic murmur. The intensity will remain constant. In pulmonic stenosis, I am starting the murmur right from S1. You know the reason why I started from S1, because I'm talking about the severe PS, where the pressure gradient between RV and PA was as much as 50 millimeters of mercury. And with respect to a pulmonic regurgitation, in fact, I'll use two different colors to highlight because S2 is gonna be A2 and a P2, and the problem is in the pulmonic valve. So the diagrammatic representation would look like this. Right after P2, there's going to be a decrescendo murmur developing in the patient. If you can draw this table by yourself under shortest possible time, then you definitely are having a hang of the valvular regions of the right side of the heart. Plus, I have also taught you another keyword, pulsatile liver. I mean, this definitely helps you crack the question. I also told you that in TS, it's going to be a pre-systolic pulsation. In tricuspid regurgitation, it's going to be a systolic pulsations of the liver. So these are a couple of aspects which, if you are able to get right, then you will be able to, on your way, to get the questions right on these topics. So keep the pressure on, keep on learning new topics every day. And as you keep on moving down in the sequence in the app, you will realize yourself that you're becoming mentally more stronger, because medical science is all about regular practice. It's not about IQ level, it is about regular practice and effort that you can make. And if you are able to do this on a consistent basis, daily study, daily learning new things. I mean, you wake up and you say, okay, it's not the social media that I'm going to hit. I'm going to hit on the app, and I'm going to listen to the videos. I know it looks initially difficult, but then once it becomes a habit for you, you guys are definitely going to be on a different plane altogether. The thought process will dramatically change. And try doing this. As I've highlighted in the initial part of the video, 5 hacks to clear NEET PG. I mean, if you are just going to dedicate 15 days of your life to general medicine, I assure you the fact that you will emerge out stronger, more positive, and definitely a better doctor. Thank you so much for your precious time and hearing me out.